Here we go. Okay, so you can see, I can see as well. I'm not sure, John, whether we're on number 6 or 7 on our series. So as Alex has just talked about, changes in sleep patterns very nicely. And as you've said, Alex, as occupational therapists, it's really important that we are aware of these changes in sleep patterns, so that we've got a full picture when we're working with a person with Huntington's disease. I mean, it's really important that we're aware of night habits as well as day habits, and vice versa, because there will be an effect. And as Alex has said, when people with Huntington's disease are asked about sleep, the most common difficulties that they express are, in terms of sleep disturbances, are the things we've listed here: the difficulties falling asleep, or once asleep then waking at night, the insomnia that Alex has spoken about. Pain. I mean, I know from my experience, my working has been with people with HD who haven't necessarily been able to express that pain. So that's a really good reminder for me, working with people with late stage, that maybe that can't be expressed, but the pain is still there, and people are quite often on pain medication. And then Alex has talked about night terrors, waking during the night. I mean, it's quite normal for us to wake during the night 2 or 3 times, but it's the getting back to sleep can be really difficult. But some of the reasons for waking up can be the need to go to the toilet, and the need for food as well.
I think that's really. Oh, sorry.
No, you carry on.
And the amount of people that I know who actually will wake up due to hunger, who have HD, is massive, and it's a really, really important issue to bear in mind. My dietitian colleague Jude will say, if a person's hungry in the night, that's fine. 10 what does she call it, 10 aero choc chip mousses at midnight is absolutely fine if that's what sends a person back off to sleep. So yeah, sorry, I've just popped in from my brain.
No, that's absolutely fine. And of course, a consequence of poor sleeping at night can be the daytime, catnapping or excessive sleeping in the day. But likewise, is that excessive sleeping in the day causing the problems come nighttime of difficulty falling asleep or waking up in the night? So it's understanding that in terms of how we might be able to make suggestions.
Yeah, it's actually very, very difficult to untangle, which is why you really need to untangle it with a person that's familiar with this problem. Because, for example, I was just thinking about nightmares and terrors. Knew a gentleman that could not communicate, but was waking up screaming, and we had to sort of try and work out what was going on. And when we actually looked at his routine, he had a real penchant for Lord of the Rings movies, and he would love to watch them because that was his thing, and he would always watch them in the run up to bed. And actually what we decided to experiment with was, is it orcs or something in that movie? They're horrible looking creatures. Anyway, we decided to stop the Lord of the Rings movies prior to bed, and actually he then stopped waking up screaming, and it appeared that what was fueling some of the terror or the nightmares, bear in mind that he couldn't communicate, that's what was going on. So it's again really important to know routine, tweak it a little bit. He replaced it with Michael Jackson videos, by the way, so I'm not quite sure what's worse.
But that takes us on to exactly what Alex and I talked about when we put this presentation together, was how important it is to document observations. And we've talked about this before. We've talked about A, B, and C's. So what we're talking about is an antecedent, or what's happened before a behaviour. So what happened directly before the antecedent, and then this is when you're documenting. B, what is the behaviour? Write it down. Tell us what the behaviour is and what the consequence of that behaviour was. So Alex's example of someone who was having night terrors, the antecedent for him clearly was watching this particular type of movie before bed. The behaviour was him waking up, having night terrors. The consequence of that was that unbroken sleep and that disruption and that distress for him. So as Alex says, understanding that, getting that information, understanding it, and some trial and error as well. It could be a number of things. And that's what we're going to look at now, are potential solutions. These are things that as occupational therapists, we would consider. And that's what we're moving on to. We're not going to say that everything works, but these are some of the things in our toolbox that we would suggest and want to look at. So we'd want to be asking families, asking carers, staff members, what's happening before, what's the behaviour, and what's happening afterwards. So in terms of the bedroom environment, we want to try and promote a quiet, restful environment, a place where you want to go and it's relaxing to try and sleep. Sounds really obvious. I know this is for all of us, to turn off the TV, radios, phones, computers. And there's a lot of studies now for the general population about use of phones before bed, and turning them off, not having them next to you when you sleep. So we would recommend to encourage that restful, quiet environment, to turn off the TV particularly, and 30 minutes before going to sleep, not immediately, but 30 minutes before sleep. If you want something on, the radio is less stimulating than the TV. Consider the room temperature. So we're told that you want your bedroom to be cool, but not too cold. So 18 to 20 degrees is what's recommended for all of us for room temperature. And that leads us on to think about the type of bedding. So if we get the room temperature right, are the duvet, the blankets, are they right in terms of someone not overheating at night, but also not waking due to being cold either? And then when me and Alex were talking about bedding, then we started thinking about the actual physical bedding, fitted sheets versus loose sheets. I'm thinking about people with movements, beds, sheets are becoming twisted and entanglements. So a bed that's going to stay as you've made it when you get in. We also talked about all-in sheets and pillows, so that if the person moves, the sheet and pillow remains in place, so you're not losing that off the side of the bed. Is there anything to add, Alex, to bedroom environments?
Temperature, I suppose, because we know that temperature sensation gets altered in HD. Lots of people run hot. Some run cold, but mainly people run hot. And so it can be quite difficult if you're sharing a bedroom with somebody with Huntington's disease, because you might find that it's a really great temperature for yourself, but actually it might cause tensions because they might be finding it too hot. So it's about, there is no ideal with this. This is about trial and error and coming to a happy medium. That also leads me on to talking about bedding. You're absolutely right, because again, if you're running hot, you actually need an appropriate bedding to stop you feeling more agitated. Because I remember once going on an aggression management course, and a wise psychologist said that you never saw a riot in a cold country. There was apparently one historical example he could give, but everyone gets agitated in the heat. and particularly so folk with HD. So it's a really, really important consideration, but often an invisible one that you need to consider. That's where I'd go.
Okay. Sleep hygiene is a term that is used not only by occupational therapists, but we certainly use it. And when we talk about good sleep hygiene, we're thinking about a routine, a pattern, a consistent bedtime routine pattern to get used to, so that there's that consistency and routine. And within that, there's quite a few components which we've listed here. Alex has talked about medication. We know that medication with HD can affect someone's levels of arousal. That could mean increasing their arousal, but also it can be a sedative effect as well. So it's really important that you have these kind of conversations with the GP regarding the effects, the side effects of medication, and the time of day they should be taken as well. I know that Alex, you've talked about people with medication and not always taking medication because of the fact that it does make someone drowsy, and then you're not getting that interaction that you might want to have with your loved one because of the effects of the sedation and falling asleep.
But there's a balance to be had here, and whilst you've put discuss with GP, I would say that GPs are great, but remember they're general practitioners. So actually, if this is a real issue, you should be asking to see a neurologist, HD specialist or sleep specialist. Yeah.
Encourage exercise and engagement in the day. Exercise, we know there's been many studies about exercise and the positive effects of exercise and sleep. But I've put on engagement as well, because not for everyone exercise is as simple as going out for a run, going out for a walk, but I've put engagement as well in terms of not thinking about just physical engagement, but social and cognitive engagement. That's really important, that during the day there's different stimulation. If going out for exercise is difficult, it doesn't mean that going out for fresh air isn't important. Even, you know, you're not necessarily going out to do a run, but just going out, getting some fresh air, just different stimuli in the day is really important. Avoiding naps in the day, that's really easy to say and really hard because someone is tired, they are tired, but I certainly, with some of the people that I work with now and worked with previously, we've looked at scheduling sleep times into the day, and that's part of that sleep hygiene. So someone is getting up for 9 o'clock, and then after lunch, maybe 2 o'clock, 1:30, 2 o'clock, having a period in bed or in their chair where they are having a low stimulus time, the opportunity to nap, to recharge, and then getting up again later in the day for more stimulating environment and for an evening meal. So it's about the routine.
Definitely. I think, you know, you said avoid naps in the day, but programming it in for people, because we've just spoken that people can have really profound fatigue. People who are moving an awful lot or using their brain an awful lot, that is using up your battery power right there. And so programming it in, but being quite boundaried around it with routine and structure is also very important, because it also helps manage things such as apathy, for example, which we've spoken about in other webinars, which is very, very important. And the treatment for that is structure and routine. Yeah. So all of these things impact on something else.
Yeah. And then we talk about consistent bedtime routine. So what we're looking at is setting a pattern again, setting a routine, an everyday pattern for getting ready for bed, for going to bed. And within that pattern is the actual activities you're doing, such as having a bath, a shower, cleaning your teeth, changing into night clothes. But also the time you're going to bed as well, trying to keep that as consistent as you can. So if you're going to bed for 10 o'clock, are you starting your bedtime routine about 9 o'clock? If you want to be asleep by 10, turning the TV off at 9:30. So having that half an hour downtime, de-stim time before bed, possibly reading or listening to an audiobook. And this, I've put about consistent bedtime routine, but also within that sleep hygiene is a consistent getting up as well, to try to think about what that 8 hours looks like. So if you're going to bed at 8, 10 o'clock at night, what time are you waking up and starting your day? Food and drink. So it's recommended to avoid large, big meals before bed. I think recommendation is 3 to 4 hours before going to bed, have your large meal. And that goes the same for caffeine and alcohol. And we're saying that, but we're also saying people with Huntington's disease do wake up hungry. And as Alex says, I know folks that will wake up hungry and they'll eat in the evening or overnight and then go back to bed. However, a light snack in the evening can help avoid that waking up and being hungry. So such as having a glass of milk, a banana, something light rather than a really big heavy meal. Okay, Alex is answering a question there, so I'm going to carry on.
I was. Somebody had asked about activity with folk with advanced HD, and I was just talking about using the pool activity level tool, which is a really easy tool to work out the person's cognitive impairment and its impact on activity, and then designing, if you like, the appropriate activity based on their personal history and what they might like or what they might dislike. But by level of activity, I mean actually breaking down the activity, whether the activity is at a sensory level, because not everyone can engage in a whole activity. So that's what I was just typing in right there.
I think also with late stage HD is thinking about the length of the activity as well. So an example might be a music and a relaxation session. I've run music sessions where we've listened to people's favourite artists, for example. So we've had a group session and people have brought their CDs, or if someone can't say what they would like, we've looked at their life history books. And it's just thinking about how long that activity can happen. It might be a 20-minute activity rather than an hour activity, and then a relaxation session after it again, and a whole hour of led relaxation might be too long. You might be looking at a shorter session. Can't get the word out. So yeah, it's not only the physical activity you're offering, but how long as well.
Yeah, I'm not thinking about activity in terms of leisure activity as well. Everything that we do is activity. Engaging with that person is activity. Holding their hand is activity. So it's thinking about it differently too.
Yeah. Okay. So putting on our occupational therapy heads. So we've talked about sleep hygiene and reasons why someone might have difficulty sleeping. Now we're thinking about the physical equipment in a bedroom and keeping somebody safe in their bed and in their surrounding area of bed routine. So we would be thinking about assessing a person and thinking about their physical ability to transfer in and out, of bed, but that's also bed mobility, how they're moving within the bed as well, and also their cognitive ability to be moving about in bed and transferring in and out. So certainly my experience working with people with late stage HD, I'm going to be doing the physical assessment if I can with a physiotherapist. We work quite closely together when we're looking at someone's mobility and balance. So mobility, their ability to sit, to stand, to lay down, their sitting balance on the edge of a bed. If someone hasn't got sitting balance, I'm then not going to be assessing their ability to lift their legs and feet up to get into bed. Their ability to coordinate the movement. And that's really important if I'm starting to think about using standing aids or equipment. And again, equipment, if I'm thinking about a rotor stand to physically help someone stand and turn, I need to then start considering about their ability to grip and hold on to the equipment. And involuntary movement. So what I wouldn't want is someone damaging themselves on a heavy piece of equipment, for example, to get in and out of bed. And then cognitive ability. So someone might physically have the ability to stand, turn, lift their legs into bed, but it might actually be their understanding and their ability to follow the instructions from staff to do it safely that becomes more difficult. I have worked with quite a few people with HD who can still get in and out of bed, but it's become so fast that, and their movement's been so involuntary that I've needed to encourage them to slow down to maintain their safety, because they're banging themselves and hurting themselves and an increased risk of falling. But actually to slow someone down, they've got to understand the instructions I'm giving them. So that often leads us to breaking down instructions into smaller stages. So rather than lift up your legs, well, that's quite simple actually. Rather than sit down and lay down, I'm breaking it to walk to the bed, turn around. Can you feel the bed on your legs? Can you put your hands down onto the bed and then sit? And when someone's got their balance, asking them to lift one leg up at a time. Really difficult, because impulsivity is a large part of Huntington's disease. It is a cognitive element that we observe. So be prepared for someone not following what you're doing, which leads me to think about the bedroom environment and my risk assessment. So we're going to go on to risk assessments. I hope that makes sense.
Makes perfect sense. But I would say you have to plan it as a bit of a military maneuver. You have to go in with your HD radar into the room before you do your assessment and go, right, okay, this is going to happen potentially, this is going to happen potentially, this is going to happen potentially, before you even get there, because you know that that's going to be problematic for that individual. Then it enables you to focus on your assessment without suddenly going, oh crikey, they've lurched forward ahead of time, ahead of my instruction. The other thing that I'd say is really quite difficult for people when they're doing this is actually that tendency, like you and I have to do on here, is to chin wag, and you're just like filling in the silences. But you've got to remember that this individual has information processing problems as well. So you've got to be 10 seconds. You've got to wait for the response. You've not got to fill the void. It's a very different way of working.
Yeah, but having that understanding of Huntington's disease will really help you in your assessment. Occupational therapists, physiotherapists, nurses, they'll all be very aware of our manual handling assessment. So when we're assessing someone's ability to sit, to stand, to transfer, it's really important that we're considering not only the person with Huntington's disease, but actually the carers, the family members, the staff as well. So your loved one might be managing quite well to get in and out of bed, but we have to think about your risk in terms of helping. The best way to hold someone, the best kind of equipment to use to help someone complete that physical action of sit to stand, or lifting legs into bed, or how to roll someone over in bed, or reposition someone in bed. That all comes part of our manual handling assessment. So we're looking at the individual with Huntington's disease, but we're also considering for their safety and the safety of staff as well, how many staff are best needed to help someone if they need help. When we as occupational therapists start bringing in equipment, we have to again think about the risk and think about, actually, are we making the risk of someone falling or tripping higher than not using a piece of equipment? And something that comes straight to my mind when I'm talking about falls and trips is the use of, and we've got some photos in a minute, the use of falls mats. So a padded mat to go beside the bed because someone's at risk of falling out of bed. That can work really well to prevent damage to someone if they fall out of bed. However, if they're getting out of bed independently or impulsively, and they're standing on a mat which isn't firm, that can increase their risk of actually tripping and falling. Or there's now a mat in the bedroom which has got a big edge, and they can walk and trip on that mat. So equipment is great, but there could be a risk to using a piece of equipment. I talked about using a standing aid. That wouldn't be appropriate if someone's got really gross, large career movements and isn't able to maintain their grip. We need to consider entrapment. So if we're using a bed which has got bed rails, we've got a potential risk of entrapment, not only between each of the bed rails, but also between the bed rail and the mattress platform. So that's something to consider and risk assessment for. And then you've got your bed rail risk assessments, which should pick up, is there a gap? And also pick up that the height of the mattress and the bed rail is adequate. So it's really important when you start thinking about mattresses, for example, that we don't have mattresses stacked up on top of each other and then the bed rail isn't high enough to keep someone safe in bed. So when Alex and I are doing our assessments, we look at the top of the mattress and we make sure there's a 22 centimetre gap, no less than that, between the top of the mattress and the top of the bed rail. We also have to consider about capacity, someone's ability to agree to using bed rails and to understand the risks and the benefits of bed rails. If we put bed rails up and someone is not in agreement or doesn't understand, they might try and climb over the bed rail. And that's a greater height to fall than a bed with no bed rails. So there's a lot of things to think about with your person with HD and family members and carers about using equipment and then increasing the risk. Ultimately, we all want to keep someone with HD safe in bed and around bed, but there's certainly quite a few things to think about. And if somebody hasn't got capacity to make the decision that using a bed rail is going to keep them safer than not, then a decision has to be made in their best interests. And that's when the team, the MD team, will come together with family members to make a decision on behalf of the person. Would you like to add anything there, Alex?
No, I would just say that capacity assessment is super important right throughout any of these issues. If you suspect at all that the individual is not understanding, then it is your duty to actually follow that through by looking at capacity, because we are talking about individuals who, yes, they might understand what a bed is. Yes, they might understand what a bed rail is, for example, but can they put all of those things together, retain and recall and weigh up the information relevant to the decision? And if they're not doing that, then this is the route that you have to go. And it will also help you establish, if you like, a strategy. It'll also help you advocate for your patient or for your loved one as well. So don't be afraid of it, because lots of people are. So they do avoid them, and then we get all sorts of sticky messes. So, yeah.
Thank you. Okay. So equipment might be needed to actually physically help someone get into bed or sit up in bed. So we're just going to quickly go through this slide. So a manual handling belt. So for someone who's actually mobilizing themselves, a belt that goes around the pelvis area, the waist area, would just is used as a way of guiding a person. It's not for lifting someone or preventing someone from moving. It's a way of carers guiding someone. You can Google all of these items. A bed lever, that's just goes on the side of the bed to help someone support themselves when they're sitting on the bed, or if they're pulling themselves up from laying into sitting. Any piece of equipment we've got to consider, as we've said, the impact of someone with career movements. The bed lever, a stand aid, they're all quite robust bits of kit. Stand aid, as it says, assisting someone to stand and transfer. So if someone is able to weight bear and stand, but actually it's become really tricky to turn your legs and sort out yourself against where you need to be, a piece of furniture, a stand aid will assist you to stand, and then can be used to turn you, to put you in the right position to then sit down again. So really useful, just from sitting on the edge of the bed to then moving into a chair, for example. I think there's an image there of a standing hoist. We've talked about full hoists previously. And then I've just put on there slide sheets and a four-way glide. So slide sheets and four-way glide sheets are really useful when a person is in bed to help move someone. So for example, if someone is moved down the bed, you can use either of these to move them back up. And also incredibly useful for rolling as well. So if someone isn't able to reposition themselves in bed, it's really important in terms of maintaining their pressure areas that they are not staying in one position for 10 hours a night. If they're in bed for 10 hours, then the position needs to be changed. So the little photograph there is of a Wendy-let four-way glide sheet system. And that actually stays on the bed. The person sleeps on that sheet, but two carers, without having to disturb the person, can move the person in bed up and down or side to side. So do speak to your OTs, do have a look at these systems. Both the slide sheet and the four-way glide sheet would have to be used by two people, two carers, to be used safely.
Ah, right. Well, that's interesting, isn't it? Because in community, no, because they come as part of one-handed care. Yeah, they're being used as one-handed care. And it really does depend. You have to just, you literally will have to work it through to see, because obviously Perhaps if you are a family member, you might not feel confident doing that. So it does very much depend on local policies and all kinds of things, Kirst. So I think that's really important. Yeah, issued for one carer in the community, Rachel is saying.
Okay,
And me
you.
too. And I was just about to say, also using this, the four-way glide, actually on a sofa, because the gentleman refuses to get into bed. With wedges, and it works quite well. And it also works really, really well to keep him, so he'll come right down the sofa, and we use the four-way glide with the fold as it folds underneath, and to try and keep him to the top with a wedge when he's actually eating and drinking on the sofa. So it works quite well. You just have to get a little bit creative, and you can do that providing you are following the manual handling regulations and good back care principles and all of those kinds of things. You really know. Oh, it sounds terrifying. Rachel's saying terrifying. It is terrifying, but it's okay. It's all right if you've worked it through. You have to work it through in stages. Okay.
Thank you, Alex. You can see where my experience of working in care and specialist settings, where we have the luxury of staff so different to the community. Okay, I'm conscious of time, Alex.
Oh yes, okay, let's crack on.
Okay, so choosing a bed. There is no one perfect bed. Like there's no one perfect wheelchair or chair or manual handling aid. So these are all things to consider. It'd be great, wouldn't it, if there really was just one thing that would suit everyone, but no.
Well, you know, we've put a bed at the bottom there, haven't we? We like the Kinderkey bed. It's called the Stellan Complex Care Bed. And that's pretty fabulous design. I think the picture that you've got is a HD bed, is it? Or is that the Stellan?
That's the Kinderkey.
That's the Kinderkey, that's that. Oh, okay, yeah.
I've got some different ones on accessories. Yeah.
So I think the other thing that we were saying here is actually, we talk about beds. I think we've talked about this, didn't we, previously, is that actually sometimes people have to be on the floor too. So I know we tend to think about beds very traditionally in terms of the beds that you and I sleep in, but sometimes it can be really, really complicated. Obviously, my man who doesn't sleep in a bed and sleeps on sofa, but also encountered people that have to sleep on the floor, but you make it as dignified as possible. So it's really important to think about that too. Sorry, Kirst, I digress.
No, you don't at all. No. So we've just mentioned about single beds, double beds, or no bed. So if you are looking at replacing a bed, we've put standard beds on there, which of course in the early stages of HD, absolutely fine. But there become a point if you need to start using equipment, for example, you're using a hoist and you need to have a gap under the bed to put a hoist in. So there might become a point in someone's journey with HD where a standard bed is no longer used, can no longer be used. But as Alex said, it's not as simple as there is one perfect bed. There could be so many considerations. If you are looking at a nursing bed, then you can start thinking about the height adjustable. So height adjustable, you can get low bed. So we're talking earlier about someone who is falling out of bed and a bed rail isn't suitable, then a low bed, a bed that goes down to 20 centimeters to the floor, might be useful. Height adjustable beds in nursing care, really important, because we're thinking about carers' backs, and we're thinking about when the carer is using a slide sheet, doing personal care, managing posture, then it's got to be the right height for the carer. Profiling beds which have Trenenberg actions. So profiling, that's the ability to raise someone's head and the ability to bring their knees up. I often call it a knee break, because I would always raise someone's head with the knee break to stop them going all the way down the bed. Trenenberg action actually allows the whole bed to move. So a flat bed, it allows the head end to be raised or the foot end. And I've used the Turnenberg action to raise the head to help get a good posture for eating and drinking in bed. So the profile will allow the head to be raised, and then the Turnenberg will actually tip the bed up as well. Lockable handset. They don't all aren't all lockable, but actually it might be that you want to set the bed, set the profile, and then lock it so that it can't be accidentally moved by anyone. What we don't want is a bed to be lowered and someone's not in it, for example, but on the floor. Length of the bed, it sounds silly, but think about the length of the bed. We're all different shapes and we're all different sizes. A standard bed is 200 centimeters, and I've worked with many really tall gentlemen, and a standard bed is not adequate for them. So many beds now will have the option of increasing the length of the bed by 20 centimeters. And then if you're doing that, you need to think about having a mattress the right size, so a mattress infill. If you've got rails, you need to think about them being extended. If you've got bumpers on the rails, they need to be extended. But actually, can make a huge difference to someone's quality of life to not have their feet at the bottom of the bed causing damage. So things to consider. And the maintenance of the beds as well. And I've always worked in healthcare settings, so I've been quite lucky that we've had a maintenance program where people on site to check beds over, but also yearly checks as well. We've always talk about equipment and HD, and it can get quite a battering. So it's important to know how to ensure that it is maintained.
Definitely. And again, so in the community, really important that, if you're getting it through, say, your local equipment provider, that how often it's going to be serviced. And actually, if it starts to get a bit rickety and somebody's got quite forceful movement, it's about keeping on that. Who is responsible for that? Actually, if there are carers going into somebody's home, do you build it into their policy that they're checking it, particularly if the individual themselves who's within this bed space doesn't have the ability to check it, for example. So it's about all of those kinds of things, which you can get tied up in knots with, but it's kind of worth sorting out, especially when somebody on a Friday afternoon is ringing up and telling you the bed's fallen apart. So yeah, very important.
And then to go with your bed, you've got your accessories. What mattress are you putting on there? Does it need padding? Does the bed need bed rails? Some beds won't have the option of putting bed rails on. Other beds will have integral rails, so they're actually part of the bed, within the bed. You can get half rails, full rails, all things to consider. I would say, working with Huntington's disease, you do need to consider padding. For some people, you need to consider padding on the beds. That can be on the outside if someone's mobilizing, walking around their room, but hitting the bed, or it could be padding for inside the bed due to gross career movements. So I've just put a couple of images there, and where they're from. There's the orthodox cocoon system, a safe side rail system. Can't recommend one. There's so many things to consider in terms of not all of the systems will allow your bed to profile. So if you need a profiling bed, then that system won't work for you. You've got to still be able to move the system to help someone provide personal care, to do manual handling. So there's no one unfortunately bed bed rail, bed padding that is necessarily going to work for every person depending on their kind of movements, but these are things to certainly consider. There's a number of different falls mats available. I've put a picture there of a high one, so actually that almost makes the bed double. You can get falls mats which have a graded edge, so if someone comes out, they roll gradually out of bed. You can get slim ones. There's a photograph there of a sensor, so that would plug into a nurse call bell system if you have that, and that would give you an auditory sound that someone's leaving the bed. So there's a lot of different accessories available to consider if you're buying a bed, what would be useful. And then mattresses as well. So I would always work with the nurses and the tissue fiability if you've got one available, in terms of considering what kind of mattress, in terms of someone's current skin integrity, someone's thinking about how long someone's spending in bed, someone's continence, someone's food and fluid intake, I can't think of the word, how frail their skin is.
Say what you're trying to say. And the other thing that I would say here is sometimes you put these things on the bed, particularly the air alternating ones, and people do sort of strange things with their positioning. So do be aware that people with HD get seasick on these beds. So you might have to have a bit of a discussion with your TVN, tissue viability nurse.
We're going to run out of time.
As per usual.
Posture in bed. So we were thinking about how you support someone, how you prevent any problems, and reducing pain. Okay, so trying to keep someone as symmetrical as possible, and think about, are you supporting them upright because they're having food, they're having drink in bed? Thinking about if they can't change, wiggle around, move around in bed, then supporting posture inside lying as well as on the back. The reason we want to prevent someone sliding down the bed, we don't want their feet on the end of the bed, we want to prevent shearing of the skin, or in prolonged postures, which is going to lead to contractures and shortening of the muscles. And if someone's in bed for a long periods of time in the day, and becomes contractured and stiff, then it's going to be really difficult to support their posture in seating. So it's really important that when we talk about posture, we think about 24-hour posture management.
Posture support, yeah, absolutely.
Not just posture in seating, but posture in bed as well.
Yeah, definitely.
And reducing pain. So some of the ways we can do that, our last slide, is the use of a profiling bed. Positioning aids to support. It could be really simple, like using towels and blankets just rolled up really tight to support the hips and the trunks. So if you're trying to give someone a drink in bed, to stop them falling to one side or the other. We've talked about wedges, Alex. They're useful in bed to help keep someone's posture, or T-rolls to help support legs. And then if you look, there are specialist companies which do specialist systems to support folks' posture in bed. Simply Stuff is a company that I've used recently. And I'm going to thank you, because I think we might be bang on time.